So this is the 7th module now of the cancer course that I'm putting together for Make Cancer History. And it's all about making very, very difficult treatment decisions. But I think it's really important to remember when you're dealing with cancer, there are only two possible scenarios. Either your cancer is kind of curable somewhere in the world, hopefully in your country, hopefully quite close to you. But yeah, many cancers found early stage are treated with curable intent. For some reason, radiologists call this radical intent. So if you're talking to a radiologist and they say the purpose of this treatment is being done with radical intent, that means they think that it is potentially curative. Or your cancer is not curable yet. Sadly, the vast majority of late-stage cancers are not treated with curable intent. Late-stage cancers typically a cancer that's spread to distant places in the body, but not always. So some cancers are staged at stage 4 if they've spread to a certain number of lymph nodes. So the spread could be quite local, but if there's a certain number of lymph nodes, that's staged as a stage 4 cancer. There are some cancers that are quite often treated with curative intent, even at stage 4. So an example of that would be colorectal cancer. If it's spread to, say, the liver, maybe one lymph node. Some countries, the standard care would be to treat that as with curative intent. So surgery to remove primary tumor in the intestine, a liver resection, and lymph dissection. I don't know why they call it dissection when you're taking out lymph nodes, but surgeons always call it lymph dissection, lymph node dissection. So even some stage 4 cancers can be treated with curative intent. But really, those are the only two scenarios. Right? You're in one of those situations. Either your cancer is curable currently somewhere, in which case you need to track down that treatment and be able to access it logistically, and sadly that often means financially as well. Fortunately, an upcoming module is all about crowdfunding, so I hope that will be useful to you. But if you're in a second scenario, which most of us are, I guess, at least on these sessions, then the cancer is not curable yet, or the cure rate is so small that we don't even want to be semi-hopeful about it. So in that case, what we need to do is still access the best possible treatment, but with a view to more treatment in the future. So we need to somehow access the emerging treatments or be ready to access them. And by access them, I mean physically ready, like your physical condition has to be good enough. And that is going to influence treatment choice. And in the majority of cases, your oncologist isn't going to agree with that, because there's a very, very strong mentality in oncology that, if it's early stage, try and treat with curative intent. If it's late stage, then you're offered palliative care. So palliative care, so sort of think of that as really pain reduction or reducing other side effects, and also extending life. But what I found with the newer emerging treatments is that the line between palliative care and curative intent is kind of blurred with the newer treatments, because the best treatments you can get tend to damage your body less, particularly damage your immune system less. They tend to open up the possibility of more treatment instead of traditional cancer treatments that reduce the possibility of treatment. If you do traditional radiotherapy, with many of the radiotherapy or forms of radiotherapy, it's one chance, right? You can't do more radiotherapy to the same place in the body. If the area was of a certain size, then you can't do any more radiotherapy, because with radiotherapy, the radiotherapist has to consider the local dose, but also your total body dose. And that can be exceeded with just a course of radiotherapy. So if we want to be in a position where we're able to access emerging treatments in the future, we need to choose treatments that aren't going to damage our body too much. And that's difficult, and your oncologist may see things very differently, because they have this mindset of the cancer spread. The best we can do is try and make the patient comfortable and slow things down a bit. Now, the approach I've taken, which has somehow kept me alive for 6 years instead of the 7 to 9 months that I originally had, or maybe a year or even 15 months looking back at better data. The approach I've taken is to have multiple treatments at the same time. So that means that certain very extreme treatments I can't do or wouldn't think about doing. So, for example, with colon cancer, there's a very extreme treatment called HIPEC. It's called HIPEC because that's one of the steps. There are typically 3 steps to this treatment. It's very extreme, and at least when I was looking into it in 2016, I was very, 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 very close to taking it. I sat there with a leading gastrointestinal surgeon in Tokyo, trying to decide if I should take it or not. And I decided against it because, at least in 2016, the way it was done would be limiting options in the future, because it's a very long surgery, 6 to 12 hours of surgery, and using some very toxic heated chemotherapy. If I was in that same position today, maybe my thinking would be different, because the treatment has improved. The treatment protocol has improved, at least in many countries, certainly in Japan. So 6 years later, that same treatment has been done quite a bit, and a lot more is known about how to select the patients and how to minimize the what's called like the morbidities, so like the complications, minimize the chance of that. So my thinking would be different, or potentially different. But in 2016, although this treatment is potentially curative for stage 4 colon cancer, I decided against it, and I took another path, quite the opposite, in fact, like combining many gentle treatments. Now, some of the gentle treatments work very well, like sometimes immunotherapy. Some of the gentle treatments probably give you a marginal benefit, but as they're gentle, you can sort of keep going. So I've had a treatment called regional hypothermia. I think I may be in Japan, I may be the cancer patient who's had this more than anyone else. I've had it something like 230 times, because at least in Japan, it's a relatively cheap treatment. It's a 40-minute procedure that you can do every week. It's very uncomfortable, but no side effects whatsoever. It's very uncomfortable doing it. They turn off the machine and you're fine. And it helps chemotherapy and radiotherapy work a bit better. It seems to also have an immunotherapeutic effect, so it can help your immune system see where the cancer is. The effect is probably very slim. I mean, we're talking about a few percent improvement over not having it. However, I absolutely detest chemotherapy. I did it for 5 years. Very, very unpleasant. So if I can do something that makes the chemotherapy a few percent better, then I will. So that would be a key bit of advice. Obviously, I'm not giving medical advice, but a key bit of advice I'd give is look at what treatments can you have that should be able to enhance the treatments that you are having. And also, when you're making decisions about which treatments to have, you need to ask, if I have this treatment, how does it limit my options in the future? Conversely, would this treatment potentially give me more options in the future? And that's becoming like a more and more usual thing. So here's another example. Many cancers spread to the liver. Now, the liver is the third biggest organ in the body after the skin, brain, and liver, I think, in that order. Liver has 500 jobs. It has this unique dual blood supply, where it supplies blood by an artery, which is usual, but also by the portal vein. Cancer tends to spread there because of the dual blood supply. Now, for some cancers, liver surgery is recommended if the patient can have it. For reasons that I don't really understand, doctors like to use the word indicated instead of recommended. So they talk about indications. So if you hear, if you're reading like about a treatment, talks about indications, that's basically who should have the treatment. And the opposite is a contraindication. I don't know why these people can't use proper language. So contraindication is the reason you couldn't have the treatment. So in many cancers, if it spread to the liver, liver surgery is an indication. But the liver is one of our vital organs, so liver surgery might not be possible. Now, an option that emerged as like a palliative treatment was RFA, radio frequency ablation. So that's putting a special needle into the tumor in the liver, heating it up with radio waves to ablate the tumor, which just means destroy it. But what's been found over the past few years is that because that treatment is gentle, now I haven't had it, but I'm sure it's incredibly unpleasant when you're having it. At least in Japan, it's often done as under sedation and local anesthetic, not general anesthetic. But it's gentle on your body. It doesn't cause decrease in liver function, right? So you can restart chemotherapies pretty much straight away if you're on chemo. And because it doesn't damage the body much, it actually opens the possibility for liver surgery. So if you're told you need liver surgery, but you have an unresectable liver, you're being rejected for liver surgery, then looking for that option of RFA may be a really good path to take. Because, if you have too many tumors in the liver for it to be resected, or the tumors are pushing against the big blood vessels, or the tumors are kind of very spread out, so it's not realistic to cut them out, RFA may be an option. You may be able to have RFA for some of the larger tumors, or the tumor that's pushing up against the hepatic artery or whatever. And that's a situation where having a treatment opens up options for other treatments. Now, for some reason, oncologists and specialists really don't want to talk about this much. It's particularly bad in Japan, I think, because doctors here really don't want to disappoint patients. So they don't want to say, oh, if you have this treatment and it goes well, you can have this other treatment. They're very kind of wary of that. And also, I think, sadly, there's a cultural thing within oncology as well, that specialists are very skeptical about each other's treatments. Now, I'm skeptical about all the treatments because I've actually, really looked into them, and lots of them, the evidence is very, very flimsy. But they're very skeptical about each other's treatments. So this is why it's really hard to get a RFA specialist to talk with you, or particularly talk with a surgeon about the possibility of doing RFA leading to liver surgery. Or another example could be lung tumors in both lungs, so it's not really possible to do lung surgery. But now, with these gentle radiotherapies like the particle-based ones, so there's the carbon ion or proton beam therapy, or these neutron capture therapies, so these very gentle radiotherapies, or things like cyberknife and tomotherapy and ViewRay, it may be possible to treat the tumors in one lung where they're spread out, and then do wedge resection, so removing part of the lung tissue in the other lung. So all these possibilities that oncologists for some reason don't like to talk about, cultural or otherwise, they have their reasons, and unfortunately as patients we have to search out these options. So when you're told you're not eligible for treatment or something like that, then finding all the ways around that stumbling block I think is really important. So if you're told you're not eligible for immunotherapy, then a very sensible question would be, what trials are happening now using this immunotherapy for patients who are not eligible for it? So an example I've given in previous modules is there's a whole type of immunotherapy called a checkpoint inhibitor, or they talk about blockade inhibiting, or PD1 and PDL1 based treatments. And it seems that the results for these treatments are good only in patients that have a thing called microsatellite instability. So they have a high level of mutation in their cancers. But since probably maybe 2018, there's been some trials for patients who shouldn't get a good response for the checkpoint inhibitors, but they've combined them with other drugs, and in a small but significant percentage of the patients, they have got a good response. So it may be that you're told a certain drug wouldn't work for you, and yet there may be trials going on that would make it, or potentially make it work for you. So a question would be, could we do a one patient case study at this hospital? Now, you're going to get a much higher chance of a yes if you're a teaching hospital, because teaching hospitals do far more research and far more case studies. I'm not sure how it works in most countries, but at least in Japan, this process can be a bit slow, because your oncologist or whatever the specialist is, they would usually have to talk to the ethics committee and say, we have this patient who will usually be rejected for this treatment, but some trials are going on in other countries, which the patient can't access, but could we do it, one person case study here? If you have a very rare cancer, I'd say that's a path you should be strongly pursuing all the time. Sadly, actually, I'm going to say sadly and stupidly, not enough research is done with rare cancers. if more research was done into very rare cancers, it's very, very likely the information would be relevant to a huge number of patients, because there are similarities between different cancers. Certain cancers behave in certain ways, and actually looking at the exceptional unusual cases will probably give better information. But if you are in a situation where you've got one of those rare cancers, then looking for a path where you can access treatment, for example, a drug that has just been approved in another country, you can sometimes still access that drug direct from the pharmaceutical company. This is often called like compassionate drug provision, I think, or compassionate care, this kind of thing. So if you see a trial, so there are trial databases that you can just go online. In the UK, Cancer Research UK has a trial database. There's an NHS trial database as well. But also you could look at health.gov, I think, which is the US like massive health portal. Their trial database lists trials all over the world. So you may see a trial happening in another country and you think, well, there's no practical way for you to get there and get involved, but could you access that drug direct from the drug company? So you look up the drug company that's doing it and you try and make a compelling case of why you need to be provided this drug. So you say, I'm here living in Newfoundland in Canada. We don't have any trials. Can you talk to my local hospital and provide this on compassionate grounds? And maybe give some compelling reasons of why they should. Now, I have a very, 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 very common type of cancer, unfortunately, colon cancer. But if I had a rare cancer, that would be absolutely the path I would be looking at most of the time. It's very overwhelming dealing with any of this stuff, but trying to choose treatments that are not standard, recommended by oncologists and stuff, that's like 1,000 times worse. So I found it helps to be kind of ultra organized about it. So for example, make a folder where you keep all the information about different treatments. Be really familiar with the standard treatment. So there are various terms for standard treatment. The one that we see most is SOC, standard of care. How they come up with that? Why isn't it standard care, but standard of care, SOC, or best practice, or standard therapy. And it's really important to really understand the standard of care and where it came from for your cancer and your cancer stage, not least because you may want to discuss or possibly argue with specialists about why they should help you access different care. So if you know about this, your standard of care for your treatment for your cancer and stage, it makes it easier to create a compelling case of why you should be referred to a certain specialist or that kind of thing. And then also you want to find out about all the emerging treatments. And this is surprisingly easy because now with Google, we can find all these very hypey press releases from pharmaceutical companies. But it's good, for example, to look at the ASCO website, ASCO. That's the American Society for Clinical Oncology. They have a huge conference every year. Oncologists and specialists go from around the world, and people report on trials there. So usually when we hear about a trial in the mainstream media, it's because the results have just been announced at ASCO. And thinking about it, those trials, will have generally started 3 years ago, possibly 5 years ago. So at least we want to, know about the ones that are coming to an end and look at the treatment possibilities there. But another idea and another question to ask your oncologist is, what trials were started 4 or 5 years ago for this, or what were you impressed by or excited about a few years ago? Because those are the drugs that are just about to become available, right? So I often see in online groups, people will share a news article about an animal study, and they'll be asking like, oh, what do you think this, here's a yogurt drink that seems to help mice overcome cancer. And the problem is, of course, animal studies are years and years and years away from human use, right? When we look at early stage trials in humans, then we might get a medicine 5 years later. So now in 2022, we really want to be looking at 2016, 2017, 2018, what was their hype around now, because some of those things will just be about to come to market, but we can potentially access them earlier, as I said, like contact the drug companies and say, I read about this trial, it was happening in 2018, what happened? Have the results been released? Are they going to be released soon? Is the drug coming to market? So yeah, this is an insane amount of work, but the payoff is potentially, living quite a bit longer. Also, it's really, really important to have another folder with all your medical records in. It's really, really vital to be, every time you have the blood test, ask for the printout. Ask for printouts of the reports from surgery, from scans, get your scans on CD, because if you hear of a potential treatment somewhere else, you want to be able to know if it's for you or not very, very quickly. So having all that medical data is really, really important. There's been a lot of interest, I think, in the last few years about different ways to both monitor cancer with blood tests and also look for new treatments. This is often called a liquid biopsy. Liquid biopsy is a very clumsy general term. People can often mean full genetic testing, like genome testing, but sometimes liquid biopsies are more focused on measuring like circulating tumor cells or free DNA. These things are all pretty inaccurate. Well, and actually the full genome testing is semi-accurate, but it's often only part of the picture, because especially with late stage cancer, of course, there's different bits of the cancer have different mutations, and tumor cells will be breaking off or escaping from different parts of the tumor. So you might not catch the whole genome, but the idea to do this kind of testing is that you may find mutations that match to certain either treatments available, possibly for another cancer. The go-to example that I always give is a certain percentage of colorectal cancer patients are HER2 mutant, I guess, or have the HER2 mutation, which means they may benefit from certain targeted treatments for breast cancer. Okay, so yeah, these knowing the mutations can help you make good treatment decisions, because potentially if you're being offered a standard of care which doesn't have a happy ending, but if you're able to find several alternatives, it may shape your thinking. So in my case, I've turned down treatments that are good, robust treatments just because they're good in a strange definition of the word where it may help you a bit and it's the best we got, so sorry, but here you go. I've turned down some of those treatments and pursued others. Another key question to always ask is, if I don't have this treatment now, can I have it later? What are the consequences of that? Now, you do not often get a great answer when you talk to surgeons about this, because surgeons want to do the surgery now, right? If you are fit for surgery, then they want to do the surgery now, because potentially it could be more tricky for them to do later on, and that kind of makes sense. But from a patient's point of view, sometimes we can try another treatment, or sometimes it is worth the risk of trying another treatment and then doing surgery if it doesn't work. Very, very good example of that would be radiotherapy for a lung tumor. Right? So if you have a single lung tumor, you may be recommended lung surgery. Now, so when I had a single lung tumor in my right lung a few years ago, I was told by the surgeon he could remove it doing what's called a wedge resection. So that's just taking a chunk of the lung out. So they take out the tumor and a little bit around it for safety. And I think he was saying 3 centimeter incision, keyhole surgery. And I asked the success rate and he said essentially 100%. So he said, in my case, being a very straightforward surgery, but I'm averse to surgery. I've had some big surgeries. Surgery's not fun. So I said, well, if I have radiotherapy on this tumor and it doesn't work, could he still do the surgery? And he sort of, mumbled and then admitted, yes, he could. And I said, I'm thinking of having tomotherapy, which is a very gentle, precise way of doing radiotherapy. It's scanner guided. It's guided with a CT scan, very accurate targeting. And it's multi-beam, so it doesn't damage healthy tissue too much. And yeah, he basically had to say, yes, you could do that, and it wouldn't really be any complication if you then, the tumor wasn't destroyed fully by the radiotherapy. So I went to speak to the radiotherapist again. The radiotherapist said, this size tumor, I think it was, trying to remember, probably around 7 millimeter tumor at that time. He said could do tomotherapy with a success rate of about 80%. Now, 80% versus almost 100%. I chose the 80% because I knew if the radiotherapy didn't work, I could then go for the wedge resection. And generally, I like to avoid surgery because surgery suppresses your immune system a lot. That's probably why sometimes after surgery there's like a resurgence in cancer. I think many patients assume it's because the cancer got kind of spread around or whatever. My understanding is that was a big issue in the early days of oncological surgery, but in most countries now, surgeons are very, very, very good at not spreading around cancer. It does potentially happen, but they're really quite good at it. So it's more a case of have the surgery that causes the immune suppression, which allows the cancer to rebound if there's microscopic cancer left, or if there were tumors that couldn't be removed for whatever reasons. Now, I think in my experience, I think I've got better quality answers from the specialists when I ask them very, very directly, what would you do in my situation? Or what would you do if your child was in my situation, or a close family member? I don't know why this is. it shouldn't work, but it seems to. And it's kind of related to this other question that you should always ask, which is, what else should I be looking at? I have found that oncologists tend to talk a lot about chemotherapy because that's what they're most familiar with. They'll talk superficially about other people's specialities. When you talk to other specialists, they will tend to talk about their speciality. But simply saying, what else should I be looking at? What other questions should I be asking? What other types of specialists should I be meeting? That just doing that seems to get more useful information. I'll give an example. I had some para-aortic lymph nodes that showed up as cancerous on PET scan. So these are kind of like, I think, deep in the abdomen at the back. And I was talking to surgeons who are saying, oh, surgery's too difficult. I asked a friend who was a doctor. He said, oh, you should talk to a kidney surgeon, because kidney surgeons, when they're dealing with cancer in and around the kidneys, often, they're removing para-aortic lymph nodes as well. So the surgery, although it'd still be challenging, that was a potential path. Now, in the end, I avoided surgery for that as well, with a combination of chemotherapy, radiotherapy, and immunotherapy. But still, it was another treatment path that was potentially open to me just from talking to a different type of specialist. Now, if you're in a situation where the options being provided to you are really limited or unattractive, the options being provided by the oncologist, there are other places to turn to. So I've said before about you could talk to drug companies directly. You can contact research institutions directly. They're generally not set up to deal with patients, and you'll generally be, you may be told that they don't take patients directly. But if you keep pushing and finding ways through, you can get some success that way. Drug companies often, you'd think they wouldn't be set to deal with patients at all, but many of them will have a patient liaison office, or they may work with certain research institutions or certain research hospitals, which they may refer you to. You can, of course, talk to other patients as well, and that is a big opportunity, particularly with the web, and also plenty of challenges there as well, because sometimes the patient's understanding of their situation is not particularly accurate, or just sometimes the situation can be really, really complicated. So you may understand your situation really well. You may post in an online group about your situation and say, have you heard any treatments that would work for me? And you get a flurry of replies by people saying, oh, I'm in exactly the same situation and I've been recommended this treatment. But their understanding of their situation may not be particularly correct. So you do want to be careful of that. When I'm posting online asking medical stuff, I have some steps I go through. So one thing is I make sure that I give enough background information that people can give a useful answer. So often I see people posting on online groups where they just haven't given enough information. So they get a bunch of replies, but they're mainly questions or completely inappropriate suggestions, and that wastes a lot of your time. So trying to think, if someone didn't know anything about my situation and I read this thing that I'm just about to post on Facebook or a cancer support forum or whatever, think if a stranger was reading this, would they understand my situation enough to give a useful answer? Particularly, you need to say what treatments you've had. Particularly, you need to say your physical location. So I'm in a lot of online groups where you'll have patients that are based in UK, for example, asking questions and not mentioning that they're in the UK. So of course, they're getting replies like, oh, you should go and see such and such a doctor at Cleveland Clinic or Memorial Sloan Kettering. So these kind of places in the US where potentially very, very challenging for UK patient to get there physically and financially, particularly if in a bad way from cancer. So also, when I'm going to ask a question in an online forum, I look over what I've written and I try and remove anything subjective, because as I'm sure you can guess, I'm often kind of irritated, cynical and skeptical when dealing with medical situations. So I'd have a tendency to write irrelevant things about being given data slowly or this kind of thing that are not really relevant to the question at all. So you want to cut out any of that, because someone reading your question, they're generally going to scan through it. So you want it to be detailed but be concise, so removing any kind of extraneous information. I always find it's really helpful to read your post out loud before posting it. That often will let you spot something which is ambiguous, or it might be misunderstood, or you've put in something emotive and irrelevant. If you're posting online, it's really important to make your thing physically easy to read, which means putting in line breaks, particularly if you're posting from a phone. When we post online from a phone, tend to get a solid block of text, which just looks hard for people to read. Even if you're posting online on Facebook or whatever, most online forums, when you hit enter, it posts straight away. But if you hold down shift and hit enter, then it will do a line break for you. Use lots and lots and lots of line breaks and lots of numbered lists to make it all very, very clear. And the last thing I'd say about posting line is it is good to have just one clear question or request. So just something like, if you're in a similar situation to me, please tell me 5 treatments you're looking into. Or if you're seeing your specialist in the next few weeks, please ask if they accept patients from abroad. Something like really, really, really simple and clear, and then you're much more likely to get a useful answer. It's a terrible waste of time to be posting on all these online groups, getting these replies, reading through and seeing that people have misunderstood what you wrote and are asking a lot of questions to clarify, or your post has been emotive and people are writing stuff about being positive or whatever. So yeah, really, really important to make use of the online forums, because it's incredible that we can access patients all around the world who have gone through treatments that we might be facing, or at least have looked into lots of treatments we might be facing. Do be very, very, very wary, though, of course, of people trying to sell you stuff, because yeah, there's no reason to trust anything someone says if they have a financial incentive to push you towards a certain treatment. And you'll get quite good at spotting that quite quickly, I think. So hopefully that has been of use, and yeah, future sessions. So obviously when you're making a treatment decision, a really big thing to look at is clinical trials, and that is the topic of module 8. So I hope you will find that useful as well.